Hello everyone. Today we will learn about ischemic heart diseases. So cardiac ischemia occurs when the blood supply is reduced to cardiomyocytes, and then reduction in blood supply leads to an imbalance between the supply and demand of the oxygen. Okay, so it is the leading cause of morbidity and mortality worldwide, and atherosclerosis is the most common etiology. But so what happens is that suppose this is a coronary artery and this is an atherosclerotic plaque, and it is causing a reduction in blood flow to cardiomyocytes. So this reduced blood flow would lead to reduced oxygen, and reduced oxygen would lead to reduced ATP. Okay, so ATP is required for two very important enzymes in the cell. One of them is sodium potassium ATPase pump. So when sodium potassium ATPase pump doesn't work properly, that leads to accumulation of sodium inside the cell, and that sodium accumulation leads to an osmotic gradient towards the cell. So this osmotic gradient leads to movement of water from interstitial compartment to intracellular compartment, that leads to swelling of these cardiomyocytes. But if this reduced oxygen supply to myocardial persist, that leads to a necrosis of cardiomyocytes and rupture of the cell membrane, that leads to spilling of cardiac enzymes into bloodstream, and we can measure these cardiac enzymes, and they are markers for cardiac ischemia. So risk factors are hypertension, smoking, diabetes, and hyperlipidemia, and a family history. Okay. So stable angina is when the cardiac pain or angina occurs at exercise but resolves at rest. Okay, so this is a predictable pain, and the blood supply is sufficient enough to meet the cardiac demands at rest, but they are insufficient to meet these demands in a state of exercise or in a state of stress. So there has to be at least 70% narrowing of coronary arteries to cause a stable angina. Okay, so what happens is that there is reduced blood flow, and this reduced blood flow, the part of cardiac wall that is most susceptible to this reduced blood flow is the subendothelial part. So let's suppose this is the endothelium, and this is the subendothelial area. So this is the area most susceptible to this reduced blood supply. So when this area is affected, this leads to an ST segment depression. Okay, so whenever there is ischemia of the subendothelial part of cardiac wall, this leads to an ST segment depression. But when the whole wall is involved, that leads to an ST segment elevation. Okay, so when there is partial occlusion of coronary arteries, that would lead to a subendothelial ischemia, and that would lead to an ST segment depression. And when there is a complete occlusion of coronary artery, that would lead to a transmural, or the whole wall is involved in ischemia, and that would cause an ST segment elevation. So this is an important concept that we have to keep in mind. Okay, so this is increased blood oxygen demand during exercise or stress that would lead to insufficient oxygen supply in these conditions, and it is resolved with rest or nitroglycerin, which is a vasodilator. Okay, so unstable angina occurs when this stable plaque, so in stable angina there is a stable plaque, so when that stable plaque ruptures, so this is a stable plaque and it ruptures, it usually ruptures at the neck, and it exposes the subendothelial collagen, and subendothelial collagen then activates platelets, and that lead to a new thrombus formation. So this is an acute pain, a sudden onset pain that occurs due to rupture of this plaque and formation of a thrombus, and this will cause mostly an incomplete occlusion, and again there is ST segment depression, but there is still no ischemia, and this is still this is still reversible, and tropes are still negative. Okay, so one step forward from this is myocardial infarction. So if this reduced blood supply persists, this lead to necrosis of cardiac myocytes. Okay, so usually from rupture of plaque. So clinical features are same as mentioned before, but they are short-lived in angina, and they are persistent in a myocardial infarction. So there is severe crushing chest pain that lasts more than 20 minutes. So if it's less than 20 minutes, it's mostly reversible. So we give rest, we give nitroglycerin, and the pain resolves, and then we have to manage them in hospital. But if it lasts for more than 20 minutes, then we have to rule out ischemia. So most probably the ischemia has occurred at this point. And the classical pain radiates through the arm, jaw, there is diaphoresis, there is dyspnea. So the patient is sweating, the patient is having difficulty breathing, and it is not relieved by nitroglycerin. So there are two types here. There is STEMI and there is NSTEMI, or non-ST elevation myocardial infarction, and STEMI stands for ST elevation myocardial infarction. So in STEMI there is complete occlusion, again there is transmural infarction, and there is ST elevation. In NSTEMI there is partial occlusion, subendothelial infarction, and ST depression or T-wave invasion. Okay, so this at this stage the cardiac myocytes have died, and their cell membranes have ruptured, so the cardiac enzymes have spilled into bloodstream. Okay, so these spilled cardiac enzymes are used as a marker of ischemia. Okay, so TROPA is one of these cardiac enzymes that are spilled into bloodstream, and it is the most sensitive and the most specific of these enzymes, and it is gold standard. So it rises within 2 to 4 hours, and it peaks in 24 hours, and then it returns back to normal in 7 to 10 days. Another enzyme is CKMB, and it is useful in detection of reinfarction. So if we see here, it returns back to normal in 72 hours. So if there is still pain after like 80 hours, and we want to see if it was a reinfarction or if the primary event is still causing the pain, we have to look for the CKMB. Okay, so because trope I would still be elevated as it returns back to normal in 7 to 8 days, but CKMB would have reduced to zero or very low levels after 72 hours. So if it is still high after 80 hours, it means that there has been a reinfarction. Okay, so another form of these anginas is a variant angina. It's also an ischemic disease, but it is not usually due to an atherosclerotic plaque, but it is due to spasm of a coronary artery. So this is a coronary artery, and for any reason it will begin to spasm. So this is wall, let's suppose, and this is wall, and these both walls. So this is an artery, and this artery spasm. This would occlude the blood flow 100%. So as we have discussed earlier, 100% occlusion of blood leads to a transmural infarction and an ST segment elevation. So there would be an ST segment elevation, but there won't be a necrosis because it is a transient state. So there would be transient reduction in coronary artery blood flow, and often it occurs at rest. So it is not associated with exercise, and there is transient ST elevation, and we give calcium channel blockers for it. Okay, so here is a summary table that summarizes everything very nicely. So stable angina, there is fixed plaque, and there is predictable pain, and normal at rest. Okay, so ECG is normal at rest, but at acute event there would be ST segment depression. In unstable angina, the plaque ruptures, there is worsening and rest pain, and ECG may show normal. That means that symptoms have resolved, or an ST depression due to a subendocardial ischemia. In STEMI, there is complete occlusion, there is severe pain, and there is ST segment elevation. In NSTEMI, there is partial occlusion, there is severe pain, and there is ST segment depressions. And in variant angina, again, there is vasospasm, so complete occlusion, there is rest pain, and ST elevation during the episode. So after the episode, the ST elevation would resolve. Okay, thank you.